What's up, Ninja Nerds? In this video, we're going to be talking about transverse myelitis. But before we get started, it's so crucial, so important that if you guys like this video, if you benefit from it, please hit that like button, comment down in the comment section, and most importantly, subscribe. All right, Ninja Nerds, let's get into it. All right, so let's talk about the etiology and pathophysiology of transverse myelitis. Now, transverse myelitis is inflammation, demyelination of the axons that are present within particularly the spinal cord. Now, what is the cause of it? We don't really have a complete, definitive answer on that, but we have some things that we think may be responsible. And this is kind of lumped into technically three groups. One is parainfectious, the other one is autoimmune, and we'll kind of label one at the end, and idiopathic. We don't really know, or we can't pinpoint a particular cause. So parainfectious causes. What does this mean? So parainfectious meaning that whenever you get infected by these particular pathogens, your body develops an immune response against that. When you develop an immune response against that pathogen, you produce particular antibodies or develop immune cells against that pathogen. But then also those immune system cells or antibodies also interact or harm our actual body, in this case, our central nervous system. It's rare that these infections directly injure the spinal cord. It's more the immune or inflammatory reaction associated with the infection. So what are these parainfectious causes that we should think about? Viruses are the first ones that I want you to know. So the dengue virus is one particular type. Okay, so dengue virus. The other one is the herpes virus. The other one is a particular type of bacteria. You know mycoplasma? So we call this one Mycoplasma pneumoniae. So we'll put Mycoplasma pneumoniae. This is a very interesting type of bacteria. So Mycoplasma, and we'll just put pneumoniae. Okay? The last one is actually a nasty little helminth worm type of infection that you see with the liver fluke, and this is called schistosomiasis. Okay? So these are the particular types of infectious or parainfectious causes that I want you guys to remember. Autoimmune is that transverse myelitis may be present or due to other autoimmune disorders. And these particularly consist of multiple sclerosis, or another one that is kind of like multiple sclerosis, but it's a little bit more intense, and it's usually more common in younger children, and this is called acute disseminating encephalomyelitis. I'm not writing all that, so we're going to abbreviate acute disseminating encephalomyelitis, ADEM. And again, the last type of etiological factor that you should be aware of is, again, don't forget about idiopathic, meaning that we really can't pinpoint a particular cause associated with this. All right, so that's the thing that I want you guys to remember. Now, how does all of this actually cause this type of pathophysiological demyelination and destruction of axons within the spinal cord? We actually don't know. There may be some type of molecular mimicry type of reaction, but we actually don't completely know. What we do know is that T cells are involved. And what happens is these T cells have a particular type of T cell receptor, and again, it may be a molecular mimicry reaction, but we just don't have a complete designed explanation of it. And when these T cells pass the blood-brain barrier and come out here to interact with these oligodendrocytes, they have a particular T cell receptor that interact with the particular proteins associated with the oligodendrocytes, like the myelin proteins or myelin basic proteins. When it interacts with it, it triggers this T cell to release various amounts of cytokines. Like what? Well, we know that it's interleukin 1. We know it's interleukin 6. We know it's tumor necrotic factor alpha. We know it's interferon gamma. What do all of these things do? They do so much. To really summarize quickly what these three particularly do is they act on the blood vessel. And they perform a couple functions. One is they increase the expression of little cell adhesion molecules, okay? And so if you have multiple cell adhesion molecules that are present on here, if a white blood cell seems to be flowing through here, it's gonna stick to that. And when it sticks to that, it'll come out of the blood and come into this area where all this, events or things are happening, where things are popping, okay? The second thing it'll also do is it'll cause the blood vessels to undergo a vasodilatory type of reaction. So it'll trigger a second type of reaction here called vasodilatation. Dilation. Why is vasodilation important? It increases the actual diameter so more blood can flow through, so you can bring more white blood cells to the area where everything's all popping. Okay? The third thing it'll do is it'll create little leaks within the actual capillary or within the vessel network so that more of these white blood cells can easily leak out or proteins can leak out. What's that called? The third thing I want you to remember is it increases capillary permeability. And so if we increase capillary permeability, you're going to allow for more proteins and white cells to leak out into this area and come to where all this type of action is occurring. The fourth thing is that these cytokines that are released may activate other T cells, maybe B cells, T cells, to infiltrate and come into this area where all this is occurring. And that fourth thing that I want you guys to remember is called chemotaxis. The next thing I want you guys to remember is this interferon gamma. You know there's another type of cell that loves to circulate through here, and it also is a very important one. This is called a macrophage. You know, whenever macrophages are circulating through the blood, they're very sensitive to this molecule here, interferon gamma. And when interferon gamma acts on this particular type of cell, it really tells this guy, hey buddy, I want you to start getting hyperactive and start undergoing some hungriness. I want you to really get hungry, come to this area and start engulfing or phagocytosing certain types of things. So that is the fifth thing that we're going to say here, is that we're going to activate this macrophage. And if we activate this macrophage, it's going to enhance like the phagocytosis process, which we'll talk about in just a second. Okay? Now, let's say that all this stuff happens, right? We increase the cell adhesion molecules, we vasodilate, we increase capillary permeability, we cause other lymphocytes like B cells and T cells to infiltrate into this area, and we activate macrophages to come into this area to get ready to start eating. What does that look like? Well, let's bring it in here. Let's say that here we bring in some other cells, and let's represent this in a different color. Let's say here we could have both T cells, but we'll represent another one here in blue as B cells. So B cells will come to this area here. So here's a B cell, okay? This is a B cell. Once the B cell gets in the area and it's stimulated by all these kind of chemotactic agents, it can get converted into another specialized cell, which is an antibody factory. And it's gonna start popping out antibodies that will really love to attack that myelin protein and really start sticking to the myelin proteins and myelin basic proteins that are present all over that oligodendrocyte. So what will this guy do? You're going to have another thing. So we have 5. Sixth thing I want you to remember here is that you're going to have an increase in IgG antibody production by the plasma cells. And these are going to tag the oligodendrocytes and myelin. When you tag them, guess what happens? The macrophages are like, who done taken and buttered up that toast for me because it look good. Then the macrophage is going to come out here and it's going to be like, that thing looks all opsonized. It looks all kinds of good. And it's going to go and engulf or phagocytose this oligodendrocytes and different components of the myelin sheath. As you do that, what happens? You start ripping off the myelin. And on top of that, there's also a lot of inflammation to the point where not only can you destroy the myelin, but guess what else you can potentially destroy? There's so much inflammation, you can even destroy the neuron itself. So not only could there be demyelination, but there could also be neuronal destruction as well, okay? So these are the things that I really want you guys to remember. Now, last thing before we move on here is that all of this type of inflammation loves to occur in the spinal cord. And it can occur at any point in the spinal cord. But the most common one, and the thing that will be asked on your exams, is the thoracic spinal cord. So the most common location for all of this madness to occur is in the spinal cord, but the thoracic aspect is the most common place in the spinal cord for a lot of this demyelination and inflammation of the neurons to occur. Now that we've gone over that, let's now talk about some of the clinical features. All right, so now let's talk about the clinical features. Now that we know that there's some demyelination and potentially even neuronal destruction, what can happen here? All right, so the first thing that I want you guys to remember, what do we say is the most common location? The most common location is by far going to be the thoracic involvement, right? So remember there's preganglionic motor neurons. right, that are particularly in a very specific location for our sympathetic nervous system. And this is from T1 to about L2, right? That's our sympathetic outflow tract. If you have demyelination or destruction of some of these axons, you're going to alter the sympathetic flow to the GI tract and the sympathetic flow to where? To the urinary system. And this is going to affect the sphincter muscles. So if you lose potential sympathetic outflow tract to the sphincter muscles around the external anal sphincter, the internal anal sphincter, and the internal anal sphincter around the urethra, what can happen? You may not be able to control your poo-poo and your pee-pee. And so what may come out is you may have some fecal incontinence and some urinary incontinence. So I want you to remember that this could lead to urinary incontinence. Now, big thing to remember here is that sometimes if there is sacral cord involvement, this may alter the contraction of the bladder, and so there could be some retention. So we'll put plus or minus retention, depending upon if there is involvement of other areas of the spinal cord. And then the last thing is this could affect, the ability to maintain holding in, and not painting the town brown. And so this could lead to fecal incontinence. Okay? Big thing to remember there. All right, so there may be some autonomic nervous system type of involvement then. Why is there some autonomic nervous system involvement? Well, remember, we're talking about the spinal cord, right? Where within the spinal cord do you particularly associate your preganglionic sympathetic motor neurons with? Your intermediate gray horns. If I demyelinate these axons, that is going to lead to these types of effects here. Boom, we good. All right, let's move on. What would happen though if I demyelinated some of the axons within the dorsal column? What could that lead to? And I'm affecting both sides generally. Transverse myelitis is you're almost affecting the entire spinal cord. So this could lead to decreased or almost loss of dorsal column sensations. How will that present, guys? Think about it, label it off. I want you to yell it off right now. They could have decrease, light touch, discriminative touch, proprioception, vibration sense, right? Next thing, what if we demyelinated some of the axons of this tract here? What is this tract? This is our corticospinal tract. It's an upper motor neuron. These give motor neurons that go to the lower motor neurons within the anterior gray horn. If you destroy the corticospinal tracts, what happens? This could lead to a upper motor neuron lesion type of presentation. Please, for the love of goodness, tell me what are the classic features of upper motor neuron lesions? What's their strength like? Well, they're going to have weakness, right? What type of paralysis would this particularly present as? A spastic type, right? So they'll have an increase in tone. So they'll have some spasticity. They also will have increased or hyperactive reflexes, increased deep tendon reflexes, and they can also have positive pathological reflexes. When you scrape the bottom of the foot, they create a dorsiflexion of the big toe and then fanning of the digits, which is called a Babinski's sign. Okay, great. Now, if I involve this spinal thalamic tract, if I demyelinate the spinal thalamic tracts on both of these sides, I alter what type of sensations? Well, this is your anterior and lateral, right? Well, the anterior carries what? Your crude touch, your pressure. So there can be decreased crude touch. There can be decreased pressure. What else could there be? Sensations. Here we'll put sensations. But if you involve the lateral spinal thalamic tract, this component, you're going to have decreased pain and decreased temperature sensations. We good. All right, the last thing here that I want you to think about, well, almost the last thing, is that if we involve or damage these spinocerebellar tracts, these are involved in carrying proprioceptive information to our cerebellum, telling us about our position in a three-dimensional space. If we lose that, we don't know where we are in a three-dimensional space, you develop ataxia. And so ataxia could be a potential manifestation. The last thing that I want you guys to be thinking about or remembering is, remember, I told you that sometimes in severe transverse myelitis, what else could you injure? The neurons. And one of the very particular things that makes this one interesting is that it sometimes can involve your anterior gray horn. So not only can you have upper motor neuron types of symptoms, but you may also have lower motor neuron lesion types of symptoms. How will that present? That'll also present with weakness, but it's more of a flaccid type. So the tone will be decreased. They'll have a decreased tone, and they'll have decreased or hypoactive reflexes, deep tendon reflexes. And sometimes they may even present with fasciculations. Okay? All right, so that is the big things that I want you guys to take away with the clinical features associated with transverse myelitis, okay? Now let's talk about diagnosis. So when we talk about transverse myelitis, I want you guys to remember, if they were to bring this up in an exam, the case that someone had a particular risk factor, they presented with these symptoms, and they say, okay, what's your first line diagnostic test? I want you to say MRI of the spinal cord, and you can do with and without contrast. So let's say that we do here MRI. And particularly since it's only involving the spinal cord, we only need the spinal cord, okay? But we should do this with and without contrast. Now, when we do this, again, which areas are we seeing most commonly affected? The most common area is going to be the thoracic spinal cord. That does not mean that it still can't occur in the cervical and lumbar portion of the spinal cord. It's just less common. Now, when we look at this and we look at a particular, maybe a sagittal section or an axial section of the spinal cord, what are we looking for? Well, there's a T1 setting or T1 look, a T2 look, and then you want to look at them when after you give contrast. And what happens is a T1 is your anatomical image. So what will happen is if there is a demyelination or types of neuronal involvement, this may show up as a hypointense lesion. So hypointense just means it'll kind of turn up black, if you will. Now, in some cases, it can be isointense, but we like to, remember potentially hypointense. But the money one is going to be your T2 or T2 flare, which will show hyperintense. Okay, and that'll show up just bright, nice and white on that section, okay? Now, if you throw in contrast, contrast happens to kind of light up particular acute lesions that may be present as compared to if this was a chronic type of lesion. It's unlikely, but usually acute lesions will show up and highlight with contrast. Okay, so this is your first line test. The second test that you can do as an extra test to aid in the diagnosis, as well as rule out other particular types of causes, is a lumbar puncture. So you're going to collect some cerebral spinal fluid. So we're going to pull some cerebral spinal fluid. After we pull some of that cerebral spinal fluid, we're going to analyze it and look for particular types of things. The big thing I want you to remember is, what were a lot of the things, like one of the biggest things, is you have lots of T cells that come to the area. You have lots of B cells that come to the area, and plasma cells, and you even have lots of macrophages that are going to come to the area to cause a lot of this inflammatory reaction. What is that called when you have an increased number of these particular types of white cells? It's called pleocytosis. Now, there isn't a lot that actually shows up in the literature about having lots of IgG antibodies. The primary thing that you will be looking for is pleocytosis, but there might be some type of antibody production that is involved because we actually may need to use a very particular intervention to clear those antibodies. All right, but big thing here, MRI of the spinal cord, look at your T1, T2 portion, and then lumbar puncture to look for pleocytosis. All right, let's talk about treatment. All right, so let's talk about the treatment of transverse myelitis. Now, it's primarily kind of an acute flare-up that is involving the spinal cord segments, right? And so another thing, when we look at the MRI, you may see multiple segments. It doesn't have to be the thoracic spinal cord that's actually involved. There could be multiple segments involved that are highlighting. But whenever you treat this person, you want to treat to reduce the inflammatory reaction. And the first line treatment, if they were to say, okay, you've diagnosed it as transverse myelitis, what do you want to give as a particular medication right away? You would say high dose corticosteroids. Okay, because corticosteroids are kind of like a very generalized, they're pretty good at just reducing a lot of inflammation. So you remember inside of the pathophysiological reaction, we said that there was a lot of T cells that were kind of leaking out here, crossing the blood-brain barrier, interacting with the oligodendrocytes, and releasing massive amounts of cytokines like interleukin-1, interleukin-6, TNF-alpha, as well as the interferon gamma, and they were kind of acting on the blood vessel and producing all those mechanisms, as well as stimulating other different types of lymphocytes and macrophages, all of those different types of reactions. Well, corticosteroids, high-dose corticosteroids, are designed to be able to pretty much inhibit this process, really reducing a lot of that inflammatory action, preventing the consistent demyelinating damage. Now, let's say that you try the high-dose corticosteroids, or you have a contraindication to the steroid use and you can't use it. A second-line agent is cleaning the blood. And so what do we call this, where we clear certain types of elements, maybe antibodies or certain types of proteins from the blood that may be involved in transverse myelitis, and then replacing it with normal healthy plasma or donor plasma? This is called plasmapheresis. So this is your second line treatment. And so what happens is, let's say that we had some of those antibodies or other proteins that are involved here in this transverse myelitis. As blood is flowing through the blood vessel, we'll take it out through this tubing and then run it through this chamber. And what it does is the chamber will clear some of these abnormal proteins or antibodies and put it into this vial here that's containing abnormal plasma. Okay? Then it'll run through the chamber and then run through this tubing to go back to the actual blood vessel. But as it's doing that, some donor plasma, right, some donor plasma or particular types of, like maybe saline with albumin and other types of solutes, are getting pushed into this channel or tubing to go back and push into the circulation. So they're going to give them back their plasma, give them back some of the solutes, but clear out the nasty proteins and antibodies to try to really reduce the immune response. These are the acute therapies I really want you to remember. Now, there is some literature that suggests that you can potentially prevent this. What are those drugs? We can use drugs, very interesting drugs that the literature suggests may be somewhat beneficial. And this drug is called mycophenolate. Okay, mycophenolate. Now, mycophenolate, what it does is it actually kind of acts on inhibiting very particular genes that are involved when they're transcribed. These genes will lead to the production of various different types of cytokines, such as interleukin-1, interleukin-6, tumor necrotic factor alpha, and so many other different types of cytokines that I'm not going to go through. But you guys remember these because they were involved in that pathophysiological mechanism. So we might be able to control or slow that process down. The other one is actually a very interesting drug, and it works on so many different types of cells that we talked about before. Okay, and it's called rituximab. Now, rituximab is basically going to inhibit the T helper cells. It's going to inhibit the macrophages, and really all of those things that we talked about before. It's going to inhibit, so it's going to inhibit macrophages, inhibit the T cells, inhibit your B cells, which will then convert into plasma cells, all of the players that we talked about over there. But it's going to stimulate one of the players that we did not talk about, and these are called your T regs, so the regulatory T cells. Your regulatory T cells are actually kind of anti-inflammatory actions. They release cytokines that say, hey, guys, chill out, let's calm down, let's stop causing this injury, demyelination, and destruction of axons. And so that is going to be some of the mechanisms of rituximab. So again, treatment, acute, high-dose steroids, doesn't work, plasmapheresis, long-term management with mycophenolate, as well as rituximab. Big thing to remember is you guys might be thinking, well, what about all the infectious causes? Those usually respond to corticosteroids or other supportive measures. So we don't need to give particular antibiotics or anti-helminth types of medications. Usually they respond well to a clear, nice case of corticosteroids, and they're pretty good. All right, so we have covered in this lecture transverse myelitis. I hope that makes sense. All right, Ninja Nerds, in this video we talk about transverse myelitis. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.